Good morning, everyone. It's really good to see the level of interest that there is in regard to the Accelerated Cluster Development Programme, or ACD for short, with so many people joining today for this event. Can I also thank you for your time, your commitment, your enthusiasm today, which is really good. It was great to hear earlier on from the Minister, from Judith, from Alex, from Albert and from Sue about the real ambitions there are for health and care within Wales, the real desire to make care close to home a reality, the real focus on out of hospital care and delivering senior services for our population. We believe that the Accelerated Cluster Development Programme, ACD, is a really good vehicle to enable this to become a reality over the coming months and years ahead. I'm going to spend the next few moments giving you a wee bit of an update on where we are in relation to ACD, what it means and what the benefits will be. I would say at this point that a lot of this is not entirely new. It is about making what we do and what we have work much better. The plan for the next few minutes is to take you through a quick history, the good work that we have done, why we began the Accelerated Cluster Development Programme, what's proposed and why, the benefits that we hope to get from that across the system, the roadmap into 22-23, what requirements do we have, and finally what this might look like, what it might look like in 2025. It's always worth beginning by talking about what clusters are and what they're meant to be. I've been doing a presentation similar to this, which a number of you will have heard over the course of the past year. And I think that definition, working as a cluster, ensures care is better coordinated to promote the well-being of individuals and communities. Everybody would agree that's what we are trying to do. And do remember, cluster working in some shape or form has been around for over a decade. The roots of a cluster working and working at a locality level were embedded in setting the direction. It's always well worth going back to that document just to read and see how far we've come. So a quick history. Yep, we have been seeing clusters in existence for over a decade. There are now over 60 clusters across Wales, and you can see the map on the right-hand side. Density of clusters in the southeast, and obviously more rural ones in Powys and Hywel Dda and parts of BCU. Clusters receive an allocation across Wales. It totals £20 million a year, and that was split into two phases. The first £10 million of finance that went into cluster working was predominantly spent in terms of helping general medical services at cluster level. So we saw lots more multidisciplinary team working as a result of that investment of £10 million, which has been really important in terms of embedding as we go forward. The next set of £10 million that came into the system was very much more focused towards the primary care model for Wales, and much less about GMS and GMS sustainability. And I'll go on in a second to talk about the good work, some of the good work that we've seen so far. So there's been loads of good work done at clusters over the course of the past decade, and that's ramped up as time has gone on. You can't help but forget and think about the primary care cluster yearbook for 2019. And if you read through that document, it's an absolute illustration of the great work that's been done through the clusters throughout Wales over the course of the last few years. Everything from community connectors through to direct access physiotherapy services to social prescribers, more pharmacists, frailty nurses, men's sheds and developments for homelessness, frailty teams, and so on and so forth. And of course, clusters have been really helpful over the course of the pandemic in relation to pulling services together and supporting people across that cluster footprint and beyond, not just within GMS, but also beyond that. So a huge amount of good work has been done, and we wouldn't want to lose any of that as we move forward with the Accelerated Cluster Development Programme. So why did we begin this journey around what was termed cluster development and became accelerated cluster development during the course of the year? You remember back in December 2020, there was a cluster survey. That cluster survey had responses from over 730 people from across Wales, from different disciplines, from different areas, from different parts of Wales. Very rich in terms of detail and thinking and issues. Those submissions we used to pull together what we thought the issues were for clusters going forward. There are many and various, but actually it probably boiled down to people saying processes remain quite bureaucratic and there is a need and a feel for wanting a little bit more autonomy in the system. As a result of the way in which finances were operating, clusters didn't really have a long-term plan or a financial strategy in many cases. Across Wales, variation in relation to membership at cluster. In many cases, it had remained as we were back in 2014, very much a GP club, and therefore the responses from clusters, from cluster leads, from other professions, from other independent contractors said that if that membership was broadened, we would get much more value. And really, what we saw was a need to clarify the future purpose and functions of our clusters, which is what we tried to do through ACD. At the same time, our current cluster leads also were doing a lot of thinking about where next. And they did some work during January 2021 across Wales. And what they were looking at, the themes that they were coming through were issues about autonomy, issues about coherence, and issues about engagement. Very keen to ensure they had the capability and capacity to do what they needed to do in terms of work going forward. Very keen to ensure we got into a position where there were longer term funding arrangements that they could play upon and be using. Very, very important in that coherence space that they were learning and sharing with each other, and that cluster became a brand across Wales. And then finally, in the engagement piece, getting access to rapid advice, and I have to say that happened a lot quicker during the pandemic and the stages of the pandemic than we saw maybe beforehand. Advocating for patients, being much more collaborative across the space, and actually being sought out by new partners, by the Health Board for Solution, by local authorities for solutions, and by other partners. And I think there is a real alignment and coherence between that which came out of the cluster survey and that which cluster leads were thinking about back in January 2021. So what is it that the ACD programme is looking to achieve? First of all, we have to be very clear that we are going to nail the purpose of our clusters, both within the planning arrangements, so they're very clear about what they're doing in planning, but also that clusters are able to deliver against the needs of the population. Very much around clusters and collaborative cluster leads, being able to influence much more than that £20 million pot, actually being able to influence at health board and local authority level the decision making and the planning for their local population. Across Wales, not every cluster has got everyone sitting around the table. There are some that have got a very multi-agency, multi-professional set of meetings. Others where, as I say, it remains much closer to being a GP endeavour. And therefore, this is very much about bringing others into the fold, and particularly making sure we bring in our local authority and third sector colleagues in there. Clearly keen to ensure that we can deliver locally with enhanced arrangements for working better, working in a more integrated way. Population health need, it's the phrase of the moment, but actually what's happening at cluster level is we're identifying population health need and then are being able to act upon it. Last but by no means least, this is not a diktat. This is about a direction of travel, and different health boards and different clusters are at different points along their journey. So this is very much about local flexibility and wanting to ensure you get local flexibility for your local circumstances. What is it that we are proposing and planning? What became very clear in terms of the engagements that I had across Wales from sort of February last year all the way through until the summer is that there was a desire to ensure that we were undertaking planning at a county level or near county level, so that we would establish pan-cluster planning groups whereby there was real traction in relation to being able to identify the priorities at a cluster level, pull that together with the other priorities and plans that would exist at a county level, and ensure that would inform regional partnership boards, health board IMTPs, and so on and so forth. Those pan-cluster planning group membership would absolutely include the cluster lead, would include our senior social services colleagues, would include local NHS leadership, senior NHS leadership, third sector parties, public health services, whether it's a director of public health or a member of the public health team, senior allied health professional, senior community nurse, the Community Health Council acting in there, and also colleagues in there from mental health and secondary care. And in that way, get a very rounded membership that was able to think hard around what the priorities were at cluster level and feed that through very clearly to our RPB colleagues. Also ensuring that when they set priorities at RPB level, they were coming down into a set of planning arrangements and you could amend them together, match them together. Over on the left-hand side of this slide, you'll see the suggestion, the proposals are that we establish at each cluster, so in each of the 60 clusters, a GP collaborative, a pharmacy collaborative, an optometry collaborative, and a dental collaborative. The GP practice collaborative, to all intents and purposes, is already there with the current sets of arrangements. Pharmacy colleagues have been working hard for a year now in terms of the pharmacy collaboratives. We don't have anything such as this for optometry, and neither do we have it for dental. So the new kids on the block moving forward from April forward, we'll be establishing those optometry collaboratives and dental collaboratives. The role of those collaboratives links in beautifully with the quadruple aim. So it's about population health and well-being. It's about improving value. It's about looking at quality and safety within those professional groupings, and also looking at workforce. Sorts of things you'd be expecting people to see: responding to local population needs assessments, sharing good practice between practices, collaborating with other collaboratives, and looking very much at what services could be delivered and how they could work better, more collaboratively with our vulnerable groups and our marginalised groups. The lead pharmacy collaborative lead, the optometry collaborative lead, the GP collaborative lead, and the dental collaborative lead would be equal members around those cluster arrangements, which would obviously include a range of other people from HPs, from nursing, from social work, from the voluntary sector, and so on and so forth. It is highly likely, in actual fact, it's needed that we have other series of professional collaboratives being commenced during 22-23, particularly within community nursing and particularly within our allied health professionals, and probably within social care as well. And they both feed into those cluster arrangements, but also, very importantly, would have a role around the PAN cluster planning group membership. Next slide. I apologise for all the writing on it, and it's a slightly busy slide, but it's something that perhaps you'd want to take away and have a look at. And it's about trying to describe that relationship between the collaboratives sitting within the cluster footprints, how those professional collaboratives come together at a cluster level, and how that cluster level work then informs the PAN cluster planning group. So identifying professional remits, then from the cluster up to identifying models and business cases, and then likewise coming down from the PAN cluster planning group, those planning priorities and funding, and that the whole circle back into those collaboratives. Really, really very important. It is at the moment sort of an evolving process, and in terms of the collaboratives, we're currently working with national organisations and through contract reform to make sure we get that absolutely spot on. Why would we do this? What might this do? We want to do this on the back of the survey, on the back of the work we've been doing over the course of the last 6 months for a number of reasons. We genuinely believe in terms of putting these arrangements in place, it will enhance integration. It will allow us to move more services closer to home, but it most certainly will improve multi-professional working. It will improve working within professional groupings that probably don't get together at a cluster footprint level already, and then begin to improve that multi-professional working, which is the bedrock of the work we want to do within our community infrastructure project, and is the bedrock of the work we really want to be doing in a cluster. We believe that this will provide a far more effective primary and community voice, both at cluster level, but also in those PAN cluster planning groups, a very, very strong voice at that local authority and health board level, county level. Around better care that's based on need, so responding to population health needs assessments rather than pet projects. It is responding to those kind of needs. Continues and allows sustainable cluster working, and sustainable in many guises, sustainable in terms of finances, sustainable in terms of long-term planning, sustainable in terms of workforce. And ultimately, we have empowered clusters that leads to better care for patients. So I think the why we want to do this is absolutely clear. And I think that with the arrangements we're putting in place and we'll be testing out through the transition year in 22-23, will show that this has been the way we wanted to go. How might that fit together? Well, if you're getting your planning right and you're doing that planning for population health need, you get that robust planning at that county level, that's great. That will probably lead in due course to those PAN cluster planning groups wanting to commission a number of multi-agency services. This is not about going back to the commissioning we had in 2003-4. Neither is about going back to where we were with GP fund holder. But actually, what you could see is there are a range of multi-agency services that we plan for and then we wish to commission to be delivered. So obesity, really important at the moment as a multi-agency service. Looking at something like care home support, again, a multi-agency integrated service. Looking at our homelessness, again, a multi-agency integrated service, which can be delivered in a number of ways, but probably at cluster level in an integrated way across the board. And it may well be one of the vehicles to do that might be through a social enterprise or community infrastructure, community interest company. Do remember 22-23 is that transitional year, and these planning groups must be linked up very, very closely to our regional partnership boards. So benefits, what's in it for you? For patients and communities, I think it means their needs get recognised and advocated for. They get better access to new services. Those services are delivered closer to home. And hopefully we start to have less of a postcode lottery within a county area. We're not going to remove that, but it helps us move towards that. If you're a local service provider, a general practice, a dental practice, an optometry practice, start to get much more clarity over what's meant to be delivered by the practice and what can be delivered at cluster level. Flexibility to be part of cluster delivery. Really want you involved in the planning, but actually you might not be involved in the delivery is a choice. Real commitments to providing local collaboration between independent contractors and the other professional collaboratives. And I believe will take away some of the unnecessary bureaucracy we have in the system at the moment. So the real benefits for patients, real benefits for local service providers. In the kind of cluster space, what is in it for you? From a planning perspective, a really enhanced profile with multi-agency partners, and what's come across over the course of the last few engagements is people are saying we missed a trick, not having clusters in our sites around this. Real ability to influence those key partners, access to mainstream resourcing and deployment, being able to localise some of the national and health board priorities, things that perhaps come through the national clinical framework, and having a bit of teeth to enhance quality provision. If you're in the delivery space, which could be against one of those community interest companies or in a different sort of vehicle, real clarity about what the event is delivered, the purpose, much more of a light touch in terms of scrutiny by health board and local authority. It's about an outcome-based approach. And then with that comes autonomy against those services which are being commissioned, drawing local key players together, a bit more flexibility and clarity over a number of years, very much outcomes driven, and a real focus on harnessing and involving all local resources. So at that kind of cluster level, if you think about the previous slide, how that all then comes together. What does it mean? What are the benefits at a local authority level? Well, clear involvement of those multi-professional cluster leads, the ability to have a county suite of priorities integrated together, focusing on what matters to the population and a consistent approach and set of services. And then at health board RPB level, clusters become mainstream and they become your key patient advocates. Real full sight of the impact of resource decisions, to be able to set those overarching principles and see them flow down and from cluster level, and then hopefully improve quality of health and well-being. So I know people like to have certainty in terms of where we are moving forward, and it's very important to be able to map out what the expectations will look like for 22-23, what people need to do when they need to do it. Let me say this is very much an evolution and not a revolution. So in Q1 of next year, we will begin to expect those pan-cluster planning groups being established and begin to see those professional collaboratives, subject to where the contract reform process gets, beginning to form, beginning to agree how they might work and beginning to look at their priorities that they've already got in place, some of those planning arrangements, and where they might best collaborate together, in particular within those professional collaboratives on those vulnerable and marginalised groups. By Q2, we start to get into the planning cycle for 23-24. So what's that look like for 23-24? What are we expecting to see coming forward in that kind of space? And ensuring we've got that clear line of sight all the way from those professional collaboratives through the pan-cluster planning groups and up to the RPB and back. Being quite bold, but in Q3, we really do need to have some of the information governance issues that have been with us and causing us issues for a number of years around cluster working absolutely sorted, solutions to the issues there, and then beginning to very much reflect on, so what do the population needs assessments have been done mean for us within our collaborative, within our cluster working, and then within those pan cluster planning groups. We will, as part of this process, for any area that's looking to move into a community interest company space, be having much more detail around how you do it, what you do, where you go in that, and support for that. In addition, we'll be looking at what our contracting mechanisms can look like in that kind of space to make that straightforward and one for Wales. And really importantly, and I can't underline this enough, one of the issues that has come up time and time again is what sort of organisational development support will we put into collaboratives and the PCPGs. There's a workshop later on this morning which will help us explore a bit more of that, but absolutely we will have a series of offers available to both professional collaboratives and pan cluster planning groups moving forward that they may want to avail themselves of. Everything from the simple how you run a meeting, how you set an agenda, how you get decisions done, through to the kind of storming, norming and forming that we'd have around pan cluster planning groups. So finally, I'd just like to thank you very much for listening to me for the course of the past few minutes. I hope that has provided you with a bit of an update in relation to where we've currently got to with accelerated cluster development, why we believe that this will really be an enabler in terms of dealing with some of the challenges that we've had in the past and the challenges we're going to have as we move forward, and match up with those ambitions that we heard about at the very beginning of the session. I'm sure that we will get an awful lot from the workshops later on this morning. But once again, thank you very much for listening, and very happy in any way, shape or form to engage with you at your professional collaboratives and your PCGs as you move forward. Thank you very much.